unmute Patil. Patil, you have to unmute.
Good evening to all. It's a great pleasure to join this Monday Muse, which is organized by Manipal Group of Hospitals, but mainly Professor Iyengar has taken a lot of interest, as well as Dr. Ranjan Shetty's help also, and he is requesting most of the academies of the country to participate in this. And today, one more academician, that Jayaranganath is going to speak on clinical approach to cyanotic heart diseases. I just want to let one-third of the infant mortality diseases and its incidence congenital heart disease 6 to 8 per 1,000. Out of that, 25% are due to the cyanotic congenital heart disease, and they may need immediate interventions for their survival. And chromosomal abnormalities, and there may be syndromic association, but mostly due to the environment factors as well as maternal viral infections, drugs and toxins in the first trimester may be able to cause, or if they are already suffering from a CHD, they are prone to have children with CHD. With this little background, I now request Dr. Jayaranganath, who is a pediatric cardiologist, professor of pediatric cardiology at JAYADEVA Institute of Cardiology. Had his training, he did his MBBS from BMC, later his MD in general medicine from Gujarat, Ahmedabad, and he did his DM cardiology at JJ Group of Hospitals at Bombay, and had his pediatric cardiology training at Royal Children Hospital at Melbourne. And he has got a vast experience and is a great academician in the field of pediatric cardiology. And I request him to go ahead with the speech.
Thank you, sir. Thank you for good introduction. And let me thank Dr. Iyengar, sir, for giving me this opportunity. Let us not waste time. This is is very difficult to cover within 45 minutes to 1 hour, and also it's going to be very boring to keep on hearing this. But I'll try my level best for the students, especially the DM students and the DNB students. It is just passing exam is one thing, but also they should know practically how to go about it, because all of them will come across these cases in their clinical practice in future. So what is the agenda here? Cyanosis, a few points, very, very basic points I'm going to highlight here. A spectrum of the cyanotic congenital heart diseases, various physiologies. This is extremely important. The hemodynamics is important. Natural history, one should know about it. That will dictate our management strategies. The clinical picture, ECG and X-ray is still relevant. And echo exams have a few, not much. Management I'm not going to cover here. Maybe we can discuss sometime later, because it's another huge topic. I don't want to confuse you. Cyanosis, this is of course this MBBS and our post-graduation knowledge. It's a bluish discoloration of the lips, tongue and extremities. All of us should know, people should know how to differentiate between peripheral and central cyanosis. Cyanosis is dependent upon the absolute concentration of the reduced hemoglobin. This is very important for you. For delineation of to appreciation of the cyanosis, clinically, the saturation should be less than 85%. If it's around 90%, 92%, obviously, unless you do the pulse oximeter, you will not be able to see clinically the cyanosis. Please remember that. And it has to have the clinically discernible cyanosis is possible only if there is a deoxygenated hemoglobin, as the reduced hemoglobin is more than 5 gram hemoglobin. This is very important in the context of anemia, polycythemia, and you should know about. These are very common questions which they are going to ask you in examination. How to differentiate between peripheral and cyanosis? I think this is a basic clinical examination. You should know it. Pulse oximeter saturation is a part of the clinical examination in the MD pediatrics, and of course in any of the DNB program and the DNB cardiology, DM cardiology exam. This is a part and parcel of the pulse oximeter saturation. And we are advocating that every newborn child across the world should have the pulse oximeter at the time of discharge. And exercise desaturation. So you have a saturation around a 90 to 93%, a balanced left-right shunt physiology. The patient, if you make them exercise, if they desaturate a bit, even it comes down to 95 to 91 or 92, that means they already some amount of right to left shunting is started. And clearly, whatever the echo picture, mildly dilated LA, LV, so many other criteria which I'm going to explain later, is there already the significant irreversible pulmonary vascular diseases setting. By and large, they are not operable. So the exercise desaturation, making them exercise in a shunt lesion, especially when you're trying to rule out Eisenmenger physiology, this is extremely important. So make them exercise. This should be a part and parcel of the clinical examination. What are the pitfalls in clinical assessment? Of course, here the admixture physiology. Can you have, sorry. Pitfalls in physiology, just a minute, I have to. Okay, admixture physiology, what are the meaning of admixture physiology? I'll give an example. The truncus arteriosus is a part of the admixture physiology, can have saturations varying from 85 to 90%, even in the infantile period, 6 months or 9 months or 1 year. So there is no clinically evident cyanosis. This is one example. So though they are classified under a cyanotic congenital heart disease, increased pulmonary flow, they are cyanotic, but the saturation, if you do, they behave practically like a large VSD. Except that unless you do the pulse oximeter evaluation, you will not see the cyanosis. Clinical evidence cyanosis is not possible. At the same time, acyanotic heart disease, large left-right shunts can develop a severe chest infection. This is a very common thing for us in the OPD practice. A large VSD, still shunting left-right, LA and LV are dilated, congestive heart failure, 4-month-old child, 5-month-old child, for all practical purposes, they should get operated. Because of some infection, intercurrent infection, which is not uncommon in India, they'll have a central cyanosis because the respiratory element is set in those cases. The primary lung conditions sometimes can mimic cyanotic heart disease, a severe bronchiectasis, some kind of a severe abnormality of the lung issues, sequestration of the lung. So many issues can have a clinical, the cyanotic picture mimicking the cyanotic heart disease. Okay. So hyperoxia test is one thing where what do we do? This is an old test, old teaching, but still relevant at times. Oxygen by mask with 100% for 10 minutes. You do the ABG. Now we cannot afford to do the ABG in a lot of situations that you just see the SpO2. With the PO2, this is a classical teaching. The more than 200 millimeters, that means it's a non-cardiac. PO2, just 150 plus, it's a less likely cardiac. Less than 150 is a cardiac. So this is still, it's relevant. So what the hyperoxia test is going to tell us and how to differentiate the central cyanosis between respiratory and cardiac. There are a couple of points here. Respiratory rate, cardiac, around 40 to 60. I'm talking about a neonate and an infant. Respiratory will be more than 70 to 80. Distress is almost always present in respiratory, whereas in a cardiac one, very absent most often. The grunting, flaring and all absent in cardiac, it is present in respiratory. Intensivity of cyanosis is very deep in a cardiac one. It's a less intense in respiratory. Response to oxygen is limited or no response. A severe tetralogy or a severe abstinence anomaly, you give oxygen. Absolutely, there won't be any great response. But in respiratory, irrespective of the severity of the condition, there will be some response or a reasonable response if you give oxygen. The depth of breathing is deep in cardiac, less deep. There is a very shallow breathing, very tachypneic, very shallow. Pulses could be abnormal in a severe cyanotic heart disease. Respiratory is usually normal. Circulation could be poor and mostly in cardiac, and respiratory is mostly normal. So this is a very classical algorithm chart which you find in each and every textbook of pediatric cardiology or in the cardiology textbooks. So we'll classify into, this is extremely important in the management point of view. And also, why it is important? Because we have to ultimately, after making the diagnosis, we have to subject the child for some intervention, either medical management or intervention or surgical. That is why making the proper diagnosis at the right time is extremely important. So we classify, that with pulmonary stenosis, decreased pulmonary flow, or without pulmonary stenosis. With VSD, that all these conditions were tetralogy, DORV, DTGA, corrected transposition, tricuspid atresia with VSD, unbalanced AV canal defect. What do you mean by unbalanced AV canal defect? So there will be two ventricles. One ventricle, either the left ventricle or the right ventricle, is small. They are not suitable for a proper intracardiac repair, or what we call as a biventricular repair. RV is hypoplastic or LV is hypoplastic. They practically behave like a univentricular heart. That is the meaning of unbalanced AV canal defect. Heterotaxy syndromes, various isomerisms, like any kind of univentricular heart syndromes you can have, single ventricles. So these are all the conditions with VSD. Without VSD, what do we have? Critical pulmonary stenosis or pulmonary atresia with intact septum. Okay, here there is no VSD. I am specifically we are putting like a Epstein's anomaly. Though obviously there is no stenosis of the pulmonary valve, we classify this under pulmonary stenosis because in a severe Epstein's anomaly, pulmonary flow is low. That's why it comes under low pulmonary blood flow setting. So somebody might question, there is no PS, pulmonary valve will be normal. Why are you including? No, this is on the basis of physiological classification to classify this Epstein's anomaly under the condition of decreased pulmonary flow. So now we have the with VSD and without VSD, very, very nicely, which is classified here. Without PS, that means here we classify into two categories. One is a normal PA pressure. You should know a couple of conditions. Normal PA pressure, pulmonary fistula. Clinically also they will have normal, very, very, very rarely you can have some kind of a continuous slow, very low, high frequency, some kind of a murmuring sound in the periphery of the chest. But by and large, I can tell you 9 out of 10 times, you will not see any kind of a murmur, normal heart sounds, normal heart size, no murmurs. This is a feature of pulmonary fistula. You do the cath, the normal PA pressure will be absolutely normal. So a lot of other conditions, unroofed coronary sinus, LSVC running into the left atrium, IVC preferentially going into the left atrium, common atrium. Initially, they'll have a normal PA pressure, but definitely after a few months or few years, after 2-3 years, if you come across any common atrium, they will not have a normal PA pressure. They will have a mildly elevated PA pressure, but not to the extent of the systemic PA pressure. That's what the classification. So you have a normal PA pressure, one set here, and come to the elevated PA pressure. Here it is being classified to 3, very classically with increased pulmonary flow. The standard, this thing is where there is a truncus arteriosus. 2 atria, 2 ventricle, but only single artery. The aorta, the single trunk is giving rise to the pulmonary arteries. Okay, practically it behaves like in the early neonatal and infancy, it behaves like a large VSD. Cyanosis won't be obvious clinically unless you do the saturation. Even then, in a neonatal period, the saturation will be around 92 to 95%. So this is increased pulmonary flow. One classical example, unobstructed TAPVC. Once again, the increased pulmonary flow. DORV VSD without PS, DTG, any of these conditions which we said in a PS with a VSD, you can put it here without PS. Same conditions. With a decreased pulmonary flow, conditions associated with increased flow initially, like a large ASD, large VSD, large PDA, with over a period of time, they develop a significant pulmonary vascular occlusive disease causing right to left shunt. Here, to begin with, they will have increased flow, but later develop a PVOD and the flow to the pulmonary circulation will be less. But if you calculate the PVR, that the pulmonary vascular resistance or the pulmonary arterial pressure, there will be systemic. Only in a AST, the PA pressure is suprasystemic. In a VST and in a PDA, always remember the PA pressure cannot go more than the systemic. The PVR might go up, but the pulmonary artery pressure will not go in a large VST or a large PDA. In ASD, they can have a suprasystemic pulmonary arterial hypertension. The other condition is pulmonary venous obstruction, which I am talking about elevated PA pressure, obstructed TAPVC and HLHS. So we'll not go into that much of detail into that particular thing. A few points. Please remember, cyanotic heart disease will have a cyanosis. Of course, they will have clubbing. They will have a polycythemia. So what we need to give importance here is, rather than diagnose the exact lesion, you can't say this child has got a DVR VVSD PS. You can't definitely differentiate between DVR VVSD PS and a tetralogy. Practically they are same. Clinically also they are same. They try to frame based upon the hemodynamics and physiology. First of all, let us see that is a PS is there, pH is there. So that is not very difficult if you apply very simple rules of a clinical examination. And of course, we need to take the help of the ECG, X-ray before coming to the echocardiogram. To know the natural history of each and every condition, and Dr. Patil sir pointed out the genetic associations. It is not uncommon. For example, I'll give an example. The tetralogy, which is a very common condition, what we see clinically, 22 to 25% of any tetralogy will have some association, genetic association. What is that? 22q deletion. So it is mandatory to screen each and every tetralogy for a genetic association. That is because it's got a lot of issues in implications in the management as well as the post-operative issues. Because they can, a lot of children with this kind of an association can have a mental retardation, to some extent learning disability, so many things. And during the surgery, we need to use the irradiated blood, but that is a different issue. So the importance of genetic association, for example, clinically, if you come across LS1 criva, it's very easy to, even without putting your stat on that, you can make a diagnosis of a common atrium. Like that, you have to have some knowledge of genetic association. You don't have to buy at each and everything. At least some common conditions you should know. Natural history. Why to know the natural history? Though I would not like to go on too much detail into the management aspect, knowing the important natural history is extremely important. Take, for example, a simple truncus arteriosus in a cyanotic heart disease. Unless you operate in the 4 to 6 weeks, they become inoperable. There's such a rapidity of the onset of the pulmonary vascular disease in this condition, in a TGA VSD without PS or in a truncus arteriosus. You cannot operate on them. 9 out of 10 times you cannot operate after the age of 3 months. So that is why knowing the natural history is extremely important. Okay, none of these cyanotic heart disease can have a normal life unless you operate on the right time. You cannot have the natural history. And most of these conditions, when you are subjecting them for a 2 ventricular repair, we are giving them a near normal life. It is not curative, of course. It is near cure. For example, in a TGA, if you operate, it is a near cure. But it's not a near cure, even in a tetralogy, because they need to be under follow. They need repeat procedures. That is why knowing the natural history of each and every condition is extremely important. One, to plan the management, advise surgery, and how to deal with them after the surgery. So this is a broad classification of the CCHV, cyanotic congenital heart disease, top physiology. If you know this much is pretty okay. Admixture physiology, TGA physiology, and Eisenmenger physiology. So what is the age of sign? I'll come over each and one later. So this is another common question you are going to be asked in the examination. So for first, cyanosis at birth or in the first week of life. What are those conditions? DTGA, HLHS, hypoplastic left heart syndrome. You don't see that often, especially in this advent of this fetal echocardiography. We are not going to see in HLHS in our country. So tricuspid pulmonary atresia, TAPVC. TAPVC, the cyanosis may not be very obvious because it is in admixture physiology, but if you put a pulse oximeter, they have to have a cyanosis. Without cyanosis, they cannot. At least the saturation will be around 85 to 90%. So any kind of a duct-dependent circulation, if the duct is not adequate and the pulmonary artery circulation is not adequate, any of the condition, they can have a cyanosis at birth. Even a severe abstinence anomaly with there is no antegrade flow, there is any intraatrial communication, they can have a cyanosis. There is no particular thing. This is in a nutshell. DTGA, definitely they'll have a cyanosis. Trichosps atresia, pulmonary atresia with a decreased pulmonary flow, definitely they'll have a cyanosis. Even tetralogy, don't think that they will become cyanotic only at the age of 6 months or 7. No. With the tetralogy or a pulmonary atresia with VST, the duct-dependent circulation, the duct is not adequate. If the antegrade flow is not very good in the severe form of tetralogy, pulmonary artery anatomy is only 2-3 millimeter, they can have a cyanosis at birth. So there is nothing like an hard and fast rule. But DTGA, yes, definitely. Some of these conditions. So make it a habit to know all this physiology, then you can apply to how to answer these questions. 3 to 6 months, you know that, tetralogy. Most of the tetralogies, almost 90% of the tetralogy, they will have a clinically discernible cyanosis in between these 3 to 6 months. After 1 year, the common condition once again is the tetralogy because the natural history, the survival is better in a tetralogy after 1 year. Abstinence anomaly, Eisenmenger in a slightly older age group. So when I say TOF in 3 to 6 months, please remember that you can apply most of the TOF physiology conditions. Like it could be a DTGA, VSD-PS. Of course, DTGA, VSD-PS, they will have a cyanosis in the first week of life. But any of those DORV, univentricular heart with PS, or univentricular heart with increased pulmonary flow, they can have a cyanosis because the PVOD is set in already. They become almost going in the nature of the Eisenmenger. Okay. So cyanosis in adults, is it common? Tetralogy, because by the nature, the natural history is so good, they select themselves. Eisenmenger due to any cause in older age group. Abstinence anomaly, please remember it's a spectrum. It's one end, you can have a cyanosis right at the first week of life. Or they need not be having a cyanosis if they don't have intrathecal communication throughout their life. Or similarly, they can be a completely mild form, except that some kind of a sound in the splitting of the M1T1 and some early systolic murmur. No cyanosis. They can lead a normal life. At the same time, as the age progresses, the abstinence anomaly can progress, giving rise to a lot of symptoms, either cyanosis or effort intolerance. So abstinence anomaly is a spectrum. So ASD with PS, there is a pulmonary stenosis untreated during the childhood. It becomes severe. There is a opened up PFO or a small ASD or a moderate size ASD. They can become cyanotic in an older age group. Rare diseases beating the natural history. We do see single ventricle physiologies, especially the decreased pulmonary flow in the second decade and third decade. It's not uncommon. Truncus, extremely rare, but still we do see. TAPVCs are not uncommon. We have seen even 20 or 30, or I have seen even a 40, 45-year-old people coming with the diagnosis of the TAPVC. Of course, by that time, they would have developed with significant pulmonary arterial hypertension. Post neonatal palliative surgeries, last follow-up for years together. Some child has undergone a BT shunt or a BT Glenn shunt, not followed up so many years, but they come to us after 10, 15 years. Obviously, if they have undergone a palliative shunt, they will be still cyanosed. So these are all some of the conditions and other conditions which you need to remember. In a cyanosis adult, you're not finding anything clinically normal. I told you the normal PA pressure, like pulmonary fistula. Please think, do the contrast echo. You get the diagnosis. It's there and there. And think of LSVC into LA. Think of IVC opening into unroofed coronary sinus. A lot of other conditions which there is a normal PA pressure, normal clinical examination, they can have a cyanosis at birth. That's why I'm talking about a proper central cyanosis without involving the respiratory issues. So systemic approach, of course, the history nowadays is the prenatal diagnosis is done. If they are staying in the metropolitan cities or even the two-tier cities. So we'll know the diagnosis a lot of times and the history of a lot of especially the child. You can take out the history from the parents or the close relatives. The clinical examination, so it has to be done. It's a must. You cannot afford not to do that. It gives a lot of information. When you want to rule out some of these conditions, clinical examination is extremely important. I might dwell into that in some case later. All this investigation, X-ray ECG is still a lot of relevance. echo, CT, MRI, cardiac cath. We use all these modalities even today in a lot of conditions. So cyanotic heart disease with decreased pulmonary flow, increased pulmonary flow, we are going to make the diagnosis. So with a decreased pulmonary flow, we'll start from the simple one, like a top physiology. It depends on the severity of the pulmonary stenosis. Fairly grow well into the infancy because of, so this is another question, common question, why they don't become cyanotic, they don't become spell, don't have a spell in the first 6 weeks of life. This is another common question for you. I think most of you know that. High affinity of a fetal hemoglobin to the oxygen. Fetal hemoglobin is more during the early neonatal period. Presence of a PDA classically closes after in 3rd week or 4th week. Reduced energy expenditure when the child is a neonate. Sleep duration is more. They're not very active. Okay, the sleep cycle is slightly different compared to the older infancy. And progressive severity of the RVOT stenosis is going to set in any case with top physiology. It matters so much. So this is the common, very standard picture of a tetralogy, a large VST, conoventricular VST, malaligned VST, pulmonary stenosis, usually infundibular, sometimes valvular, combined, once again common, overriding the aorta. These are the 4 cardinal features of a tetralogy to make a diagnosis on the echocardiogram and on the morphology. Prerequisites of a top physiology, another common question we're going to be asked. According to me, to make a diagnosis to say top physiology, these are a couple of things are extremely important. There has to be a large non-restrictive VST. This makes both ventricles contract at the same pressures. This is one. Second thing, criteria is obstruction to the pulmonary flow. Both ventricles eject in systole in unison. Where ejects, it depends on the 2 factors. One is right ventricular outflow tract obstruction or the obstruction of the pulmonary flow versus systemic vascular resistance. Severity of the obstruction to the pulmonary flow and systemic vascular resistance is extremely important. So the top physiology, then when you know this, to answer the next question, what are the conditions under top physiology, becomes easy. One is standard top, second is DORV VST PS. That means you have a non-restrictive VST, you have an obstruction of the pulmonary flow in the form of the pulmonary stenosis. You have, third condition, you have a condition TGA VST PS. Okay, there's a non-restrictive VST. That's why I said obstruction to the pulmonary flow. I did not say that's RVOT obstruction. And a corrected transposition of the great vessels with VST with pulmonary stenosis, same thing. And univentricular heart, single ventricle of so many types. Don't go into the detail. There, it is behaving, both the chambers are not there. Only one chamber is there. Obviously, the same thing, the same chamber, ventricular chamber here behaves like 2 ventricles and eject into the insystole into both the pulmonary artery and the lungs. Okay, pulmonary artery and the aorta. So this also you can categorize under top physiology. So if you know the basic how to make it diagnose, how to the definition of a top physiology is according to me like this. According to me, I'll come to that later. TOF is an interplay between RVOTO and SVR. So a couple of myths I want to just clear the doubts and clarity here. Please have the clarity in this slide. I'm going to explain to you. In all patients, please remember, in all patients, RVOT obstruction is severe. You catheterize 100 patients of tetralogy. By and large, PA pressure will be normal or less than normal. Normal means what? The peak systolic pressure is around 25 to 30. The diastolic pressure is around 10 to 15. Okay, very mildly elevated, 25, 30, 35, which is anemia and all. So if some collaterals are there in a tetralogy, mildly elevated, but by and large, the PA pressure is normal. If we take a gradient across the RVOT, there is a significant gradient in each and every tetralogy. So don't go by the impedance. There are some kind of a mild obstruction, moderate obstruction, severe obstruction. No, even in a tetralogy with an absent pulmonary valve, if you take the PA, if you catheterize the child, the PA pressure will be normal. Please remember this. What is important is RVOT resistance almost matches the systemic vascular resistance. So here, so there are 3 possibilities. One is RVOT resistance is marginally less than SVR. RVOT resistance is equal to the SVR. RVOT resistance is more than the SVR. So here we are talking about two resistances. One is the RVOT resistance and the systemic vascular resistance. We are not talking about what is the severity of the anatomical severity of the RVOT or the infundibulum or the pulmonary valve. So a few scenarios. If the RVOT resistance is less than the SVR, the QP is more than QS, pink tetralogy. Okay, but if you catheterize, PA pressure is normal. Please remember that there is a significant gradient, but they are not cyanotic. If you give the pulse oximeter and if you do exercise them, the saturation might drop. But clinically, there is no cyanosis. That means the pulmonary flow is quite good, is adequate. Classical example is tetralogy with absent pulmonary valve. Okay. Second, or in a lot of things, even pink tetralogy is what we call, they come across this, there won't be cyanosis. There is a good systolic murmur. But you do the echo, you have a tetralogy features. If the RVOT resistance equal to SVR, that means the circulation is balanced with the QP equals QS, the reasonably good pulmonary flow here also. But presents with cyanosis. Cyanosis will be there around 85, 86, 88, or 80, if you put the oximeter. But saturation will be around 85. But reasonably good effort tolerance. The pulmonary anatomy is reasonably good. That means antegrade flow is quite good here. They are good tetralogy to repair. They don't need any kind of a palliative shunts. If the RVOT resistance is more than the SVR, that means QP is very significantly less. The spells, these are the children who come with spells. They're severely symptomatic. They need something to be done in the early neonatal period and the infancy periods. So here you're talking about I'm not talking about anatomical obstruction, it's the resistance of the RVOT and resistance of system vascular resistance. Please remember these three, okay? RVOT obstruction is fixed, remains severe, irrespective of the clinical situation. So what changes time to time is SVR. Okay. So other top variants, I think these you people know about it. Other top variants are pulmonary tracer with MAPCAs. This is for a survival of a child, the MAPCA presence is absolutely important. They are needed. And top with absent pulmonary valve, top with atrioventricular septal defect, top with the double outlet right ventricle. Clinically, it is fairly easy. Tetralogy with pulmonary atresia, there won't be any antegrade flow murmur, so there won't be any systolic systolic murmur or outflow tract murmur, but you'll have a lot of continuous murmur on the back and the sides to suggest that the MAPCAs are present. The child may be relatively less symptomatic because there's a good pulmonary flow because they're MAPCAs. Absent pulmonary valve, clinical examination is very easy. To and from murmur, you are there to make a diagnosis of tetralogy with absent pulmonary valve. Atrioseptal defect, by and large, you will not be able to clinically differentiate from a regular tetralogy unless there is a AV valve regurgitation. You can start suspecting there is a regurgitated murmur. So there is evidence of tetralogy in the form of S1 normal, A2, S2 loud, and there is a systolic murmur across the silent precardium. So you can start suspecting that there could be AV septal defect. Top with a double outlet right ventricle. Great arteries are normal related. The DORVs, I don't want to go details. There are too many variants. There are 16 types of DORV on the basis of the great artery arrangement and on the basis of the location of the VSD. 4 into 4. I think you should read about that. It is another chapter. But believe me, you cannot make a differentiate. You cannot make a clinical diagnosis, or you cannot differentiate from the regular tetralogy. Each and everything will be normal here. This also we call as a top TET kind of a DORV, TET variant of a DORV. You cannot make. A lot of people do answer that some teaching will go on many times. There is an obligatory shunt murmur across the VSD. You cannot have any systolic murmur. You cannot have a shunt murmur here. There is an obligatory shunt, I agree, but RV and LV are equal pressure. It won't generate a murmur. Okay, so same clinical finding of a tetralogy, you will have any DORV, VSD, PS, where also you can call it as a top variant of DORV. You cannot make a differentiate. So top physiology, to just sum up here, we have the RV dominance, tetralogy, DORV, VSD, PS, TGA, VSD, PS, CTGA, AVA septal defect with PS. In LV dominance, tricuspid atresia with VSD with PS. I'm not including here just a plain simple type tricuspid atresia with a small VSD, which behaves like a flow to the which causes left right shunt and in turn gives a pulmonary flow. Single ventricle PS will have especially of the LV type of single univentricular heart will have this same kind of physiology. Pulmonary tracer, yes, I'm not including here. It has got LV dominance, but that does not satisfy the criteria of having a non-restrictive VSD. But clinically, it will practically behaves like cyanotic heart disease with a LV dominance. Okay, so I don't want to include completely under this particular heading. So the severe tetralogies, I know that you have understood the basic anatomy and a bit of physiology and may present with the cyanotic spell, or it could be asymptomatic and may be detected just because of the murmur. Hypoxic spells, a few slides here. Peak incidence is between the age and 2 to 6 months. Why do not they present before 2 months? I have already enumerated the causes. About 40% of the patients with cyanotic heart disease and decreased pulmonary flow develop this spell. This is clearly a practical point. So almost 40 to 50% of any of the, I'm not talking about a tetralogy, any of the cyanotic heart disease with decreased pulmonary flow will develop the kind of a spell because of various reasons. So, you know that classically that either they disappear, systolic one, either disappear or become short during the spell. Presentation of spell could be triggered by so many factors like early morning, crying, micturition, defecation, any kind of an activity. Anemia is extreme. That is why treating of anemia in a cyanotic heart disease is extremely important. We don't accept a hemoglobin of 12 or 13 grams in a cyanotic heart disease. We want it to be more than 15. Any kind of dehydration is not accepted. That's the reason that when we are catheterizing a child, especially, we want to hydrate the child almost 12 hours before the procedure. So please, you have to explain to the mothers how to hydrate the child, how to take care of all these minor aspects. So the causes, it causes cyanotic spell, causes a deepening of the cyanosis, excessive irritability, tachycardia, tachypnea, or seizures. So this is a very classical cyanotic spell. There's so many theories are there, which I'm not going to, it takes long time for explanation, all these things. I can transfer the slides and you can go through this. Very nice, lot of theories here. So this is all proved by the rapid atrial pacing. Once again, squatting or equivalents increases SVR. So, sorry. So how to treat in nutshell? Increase SVR by kinking the lower limb arteries, reduce venous return. After that, the morphine. There's some of the drugs what we give in this table. A lot of things are there. How to take care of this? What does it do? I just give one function of that. Morphine sulfate suppresses respiratory center and abolishes hyperapnea. Then soda vacar, we need to correct the acidosis, otherwise myocardial depression can happen, the child can have arrest. So in order to avoid that, it can cause a tremendous lactic acidosis because the cardiac output will come down because when there is no pulmonary flow, obviously secondary to that, the child can have a severe acidosis. And beta blockers slow the heart rate, reduce the spasm of the RVOT, increase SVR by antagonizing the vasodilating effects of beta stimulation. These are all mechanisms. And ketamine increases the SVR and sedate the patient. These are some of the drugs if the medications do not work. So what are the things one need to do? First, make the diagnosis of a spell, take care of the child, simple maneuvers like bending the knee position, then try to secure the IV line. Oxygen is not so important, though we do need to give the oxygen, and some of the drugs like morphine sulfate, the soda bicarbonate, the ketamine, phenylephrine, all these things have to be handy in management of a spell. The medications do not work. IV beta blocker, we don't get IV propranolol nowadays. We can use whatever the beta blocker is available. We use the metoprolol generally or esmolol infusion. The medications do not work. Emergency BT shunt is becoming an history of late. Emergency BT shunts are not done in majority of the center across the world. For a tetralogy fellow, we are a fairly less invasive procedure, non-surgical method. We are all doing the RVOT stenting in majority of these spells now. We intubate them, just take them to the cath lab, put the stent across the RVOT. This is the treatment of choice for a spell now. They are not getting treated by the medical management. So after a spell, what happens? See, they could have a seizure, they could have a lot of issues. Neurological evaluation is needed if needed in CT and MRI. They ought to be put on a maximally tolerated beta blocker. Oral propranolol is easily available. that you know to know this dosage, and we need to be started on beta blockers. Quickly plan early correction or a palliation. The two things you need to correct it. One spell is good enough, okay, to make the plan for what the child should need it now, either the correction or the palliation. Either the palliation, the correction depends on the single factor, that is the pulmonary arterial anatomy, nothing else. The correct HB, give blood if needed. Iron supplements is a part and parcel each and every prescription along with the BT blocker. Any child which goes out of the OPD without iron supplement, any cyanotic heart disease is a crime according to us. Avoid future spells, avoid dehydration, avoid cannulation of a crying cyanotic child. Give IM ketamine can be given. So make the child quiet and then start the line. Control fever very rapidly. So how do they present a tetralogy in general? A normal JVP is must, except in adults where A wave could be prominent because of the diastolic properties of the right ventricle and left ventricle change in adults. So it can give rise to a prominent A wave. Otherwise, it's a normal JVP. Normal heart size, a quiet pericardium, palpation will not give you any kind of an assistance. Sometimes very mild systolic thrill, uncommon, but we do see it's not completely absent. It is a possibility. We have seen a lot of tetralogists can have a systolic thrill. That means there is a good amount of antegrade flow going on. RVOT resistance, which will come back to the resistance again, is reasonably okay. A single second heart sound is a hallmark of a pulmonary atresia, Vsd or a tetralogy, or any kind of these things with a decreased pulmonary flow. The top physiology in general. Agitation systolic murmur, if there is an antegrade flow is there, it is a rule. If the Vsd is restrictive, what happens? The right ventricular pressure starts rising, then RV hypertrophy, it becomes very, very obvious. Parasternal heave can be present. Otherwise, a straightforward, simple tetralogy of Fallot, you cannot have the parasternal heave. Please take it out. So, clinical examination, normal JVP, normal heart size, you can't even feel the apical impulse, quiet pericardium, no thrill, auscultation, second or single second sound, first sound will be normal, ejection systolic murmur. These are the very cardinal features of the tetralogy. Ejection systolic murmur directly or inversely related to the pulmonary stenosis. It's a very common thing. If there is a good murmur is there, that means the antegrade flow is good. It does not tell the severity of the RVOT. Okay, ejection click, if at all if it is present, it is almost always in a tetralogy, it is IOT. In a polycythemia, murmurs may disappear. Even the pulmonary flow on the color Doppler echo may not be seen. So this is the ECG. It looks like a very standard ECG sinus rhythm, normal sinus rhythm, axis extreme towards the right, and see the V1. There is a monophasic R. There is a sudden transition. This is a very classic ECG of a tetralogy. If we have any, this is the X-ray, boot-shaped heart, no cardiomegaly. You can see that very concave or pulmonary bay. The presence of the pulmonary artery segment is a concave, a reduced pulmonary blood flow, very scanty lung markings, dilated aorta. This is almost each and every tetralogy has to have a dilated aorta. A right aortic arch in 20 to 30% in a tetralogy. A standard tetralogy in atresia is almost 35 to 40%. So DVOR is PS, extreme right axis deviation. This is not very, you can have either way. You can have extreme right axis in a tetralogy also. This is not going to give us a clue, though some books have explained to this. And some percentage of DVOR, especially the subaortic VSD, you can have a counterclockwise loop. That means 1 and AVL, you can have a Q waves. PR may be prolonged, RVH, but may not be sudden transition. This is once again plus minus, I can say. So one slide about this clockwise and counterclockwise for a postgraduate is extremely important. QRS are normally seen in lead 2, 3 AVF, V5, V6 due to clockwise loop of the VQRS vector. In lead 1 and AVL, if you see the QRS that suggest a counterclockwise look of the initial QRS vector, we need to read about it. Once again, go to the vector cardiography in all the standard textbooks and read about it. This is important. It is seen in the case of tricuspid atresia, endocardial cushion defects, inlet VSTs. Okay, this is almost most of these cases, they will have a counterclockwise loop. So if you know at least a couple of conditions where they have a counterclockwise loop, that's quite good enough. So after coming to the tetralogy of Fallot, that's a very standard one. A couple of other conditions like simple conditions like a tricuspid atresia with PS. Here, unlike the previous one where they have a tetralogy, JVP as a rule is normal, except in adults or in RV dysfunction or a restrictive VSD. Here, AVV is prominent. Obviously, the tricuspid valve is not opening, RA is contracting. JVP may be raised if the ASD is restrictive. That means the right atrial pressure is very high if the ASD is not large. If you go to the apex, this is systolic LV, another common question where there is a cyanosis only apical impulse. This is very standard one. Okay, a systolic LV impulse at the apex. RV impulse is non-palpable. You can't see even if you put the epigastrium, you don't see any RV impulse. Obligatory, if there is a PS, obligatory VSD allosystolic murmur. Okay, here you have a condition where there is a VSD. They can also have a PS. The pulmonary stenosis is a feature, but many times in a simple tricuspid atresia, the pulmonary valve will be normal, but what restrict the pulmonary flow is a small VSD. Or it has to be obligatory VSD has to be there. If there is an antegrade flow, the VSD will be muscular VSD, so 3 millimeter, 4 millimeter. So you find a holosystolic murmur or a early systolic murmur. Okay. So, or if there is a VSD is there, if the pulmonary stenosis is there, you will have a ejection systolic murmur. So this is, you see this left axis deviation, LVH with adult precardial progression. So if there is a left axis deviation, a counterclockwise loop, right atrial enlargement, and predominantly the left ventricular forces, left ventricular voltage, you can make a diagnosis of tricuspid atresia with PS. This is how it looks like in the X-ray. The aorta, this RA is obviously dilated. You don't find the RV, small RV flat inferior border. So, top physiology in a TGA VSD PS is third condition. A few slides. Cyanosis, it will be usually cyanosis, unlike a tetralogy. In most of the tetralogies are not cyanotic at birth, or at least clinically they're not cyanotic. But whereas in a TGA VSD PS, though it's a top physiology, the cyanosis will be there because this is a different kind of a cyanotic mechanism. This is here, they run in parallel. This is a transposition physiology. That's a TET physiology, is a transposition physiology. Here, what is happening here is that both the circulations are in parallel. Obviously, the pulmonary flow is coming back to this air, it is going back to circulation. So, they are, as a rule, they are cyanotic at birth on the day one of life. There is a severe cyanosis among all these, for all the top variant or top physiology is terribly cyanotic. So, since birth, so here you see right axis deviation, RVH, tall peak waves, T is usually positive in the precardial waves. So another condition is a corrected transition VSD with PS. This is one condition to start with. They are not terribly cyanotic, though the cyanosis appearance depends on this PS severity. Spells and squatting are uncommon compared to the tetralogy. This is one condition where they could just grow up to the second decade, third decade without having any surgery done. They are not as bad clinically as, definitely not as bad as tetralogies, but compared to the regular TGA or DTGA, they are much more less symptomatic. Older adults, they can have a syncope because 20 to 25% can have AV block, they can have a syncope. It is often associated, a lot of times, it's not often, it is almost 30 to 40% of the time is associated either with isolated dextrocardia, that means situs solitus dextrocardia or a mesocardia, or there is a mismatch of visceral and cardiac situs ambiguous. Loud palpable P2 in the second. How to differentiate this one with a tetralogy is you can have the S2 in the left intercostal space. Normally in a tetralogy, in a second intercostal space, you don't, you can't palpate any second sound. Here you can palpate because here the aorta comes, because here the great arteries and the ventricles are side by side. So the aorta comes in that area. So you get the palpable third of the second order sound is an aortic component. It's not a pulmonary component. Systolic murmur of PS may be located a bit lower down. not very sure. In a child, you can't really make this diagnosis. Additional murmur, if it is there, of a left AV valve regurgitation may be present. Significant number of a CTJ, corrected transposition of great arteries. Corrected transposition means what? There is a AV discordance and VA discordance. In a DTGA, AV concordance, only the VA discordance. So in corrected transposition, though it is physiologically corrected, there is a significant amount of patients can have a left AV valve regurgitation. So we have a case, what we need to follow. Once again, it's a spectrum. It's not like tautology, it's like a spectrum. Very, some people can have only without VST, or with VST, only VST, without PS. So there are various varieties are there. Here, if there is an intact septum, ventricular septum, what we need to follow up during their OPD, during the follow-up is the onset of left AV valve regurgitation. This could be very detrimental for the child. Sir, the time is running up or? Hello?
Yeah.
So time is there, sir? Time is there?
Yes.
Can I go another 10-15 minutes, sir?
Yes. Okay. Yes.
Thank you.
Suddenly I saw the time is close to 9 o'clock. That's why. Yeah.
We started at 15, so it's okay.
Okay, sir. Okay. So the systolic murmur of the PS may be looked at, but not very. So what is most important in a CTGA is a left AV valve regurgitation, because already the systemic ventricle is the right ventricle, which is not prepared for the cardiac output. That means to eject into the aorta. Already there is inherent weakness of the muscle, inherent weakness of the strain. So a lot of things are there. Along with that, you develop a left AV valve regurgitation, which is not good for the child or a patient. So that needs to be corrected. So this is in nutshell for the exam going students. This right axis deviation in RVH, tetralogy, DORV. If there is a left axis deviation in LVH, the univentricular heart of LV morphology and tricuspid atresia. If there is a left axis deviation with the right ventricular hypertrophy, you think of AV septal defect or AV canal defect with a PS or some type of single ventricle. Single ventricle is determined. I don't want to go into the detail here. There's something called a outlet chamber, a dominant ventricle. If it is a non-inverted outlet chamber, so many combinations can be there, giving rise to this kind of a left axis deviation or right axis deviation. Okay, so have this fair idea about this. So this is top natural history. The top one is a normal human being, normal survival. If they are untreated, you see how it declines over a period of years. By 30 years, majority of the succumb. If they are treated, that's the green one, they survive to the 86%. So that's the reason that it is not a cure. The counseling once again is important in tetralogy. It is not a cure. They need to a lifelong follow-up. They need surgeries, at least 2 to 3 surgeries in their lifetime. Even if you have corrected the surgery, done the surgery at the right time. So top natural history 1 year, 70% survival, 3 years, 50%. So by 40 years, only 3%. But in pulmonary atresia with VSD, only 8% at 10 years because of the pulmonary flow is inadequate. They develop a lot of problems even because of the collaterals. So this is once again for the students. The prominent EA wave physical finding are likely underlying CHD. Prominent EA in the JVP. That means to make it, if there has to be a prominent EA wave in a JVP, please remember by and large, that means intraventricular septum should be intact. You cannot have a VSD except in adult. Okay, so that means conditions are tricuspid atresia, ASD with PS, and TOF in adulthood. LV type of apical impulse, tricuspid atresia, single ventricular LV morphology. Very rarely, extremely rarely, we have come across some cases. I mean, most of us in the practice of pediatric cardiology do RV with a very restrictive VSD because left ventricle become very hypertensive because it's the only outlet chamber. That VSD also becomes restrictive, means what will happen? The LVH will develop, so they will have a LV apical impulse. It is only for the completion's sake. You don't see often in the clinical practice. Pulsation is second place. Corrected transposition of great arteries, almost always. Univentricular heart with a L malposed aorta, they can have the pulsation. That means L post aorta, they can have a pulsation in the second intercostal space. Parasternal heave of more than grade is a small to moderate cell or even a large VSD, but septum is intact. That means interventricular septum is intact, severe pulmonary stenosis. So mesocardia, dextrocardia with yes, likely underlying CCHD, situs solitus with dextrocardia or a mesocardia ambiguous, very likely it could be having a CTGA, corrected transposition with VSD with PS. Pansystolic murmur, if we hear, that means very likely in a cyanotic heart disease, possibly you are dealing with a AV septal defect or a corrected transposition. These two are the conditions where you get left AV valve regurgitation. To and fro murmur in a TOF with absent pulmonary valve. To and fro murmur also can have very rarely with Eisenmenger situation with a large PDA, but they don't have the systolic murmur. You can have a diastolic murmur, we cannot have a systolic murmur. So to and fro murmur in a cyanotic heart disease, TOF with absent pulmonary valve. Complete heart block, start thinking about CTGA or heterotaxis syndrome. Heterotaxis syndrome means either left isomerism or right isomerism, very complex congenital abnormalities, polysplenia, asplenia. They can have a lot of complex heart disease like the IVC interruption with the azygous continuation, so many conditions. You have to read a bit of heterotaxis syndrome to at least, they may ask you for the short notes. Significant cyanosis with a prominent ejection systolic murmur. Transposition admixture with USD and PS. So TOF with other anomalies, the right aortic arch 25%, already I told you, pulmonary atresia forms about 15 to 20%, LSVC, complete AV septal defect is less than 2%. A lot of conditions. Anomalous cannula arteries is not uncommon. That's why in echocardiogram, we are fairly now good in recognizing the coronary artery anomalies. If we are very clear, we don't ask for the other imaging. We just directly send them for surgery. Anomalies of the pulmonary arteries. Absent left pulmonary artery or small pulmonary artery, atretic, LPA is coming from aorta or slings. So many conditions can give variations of the pulmonary arteries. If you have any suspicion, we do the imaging for this. Catheterization in TOF often not indicated. Almost I can say 90% of the times we don't ask for the catheterization nowadays. It's only for the coronary artery delineation. It is not very difficult in children, especially when you are doing the echo in a neonatal infant. Branch pulmonary artery anatomy, where we have some doubt about the LPS stenosis, LPA coming off in a different way in a tautology or in a pulmonary atresia. In a setting of a pulmonary atresia, cath is not indicated. We do the CT scan, CT angiogram. Additional VSDs we can pick up. It's not necessary to do the cath. As a part of we do the catheterization or as a part of the RVOT stenting, as a part of the PDS stenting, or a collateral embolization. These are three things which is almost like a therapeutic indication, not as a diagnostic indication. Diagnostic purpose, we really are not doing much in almost 99% of the times. We do get the CT angiogram. So a note on the adult TOF, you see that the congestive failure, a couple of things. Dyspnea is a significant feature in adult etiology. Of course, they'll have all of them will have cyanosis, 94%. What is here in this article is that dyspnea is a predominant feature in older etiologies, and congestive failure in about 15 to 20%. They can have systemic hypertension and other things. So repair TOF, you just don't stop at the diagnosing. So you do come across a lot of post-operative etiology. What is necessary to look into that? Heart failure or arrhythmias are a common cause of death post-operatively. Don't think that you can just write off, okay, you have done the surgery, you are not going to have any problem in future. No, they have to be followed lifelong. This one to stress upon all of you. The pulmonary regurgitation and RV dysfunction are common sequelae post-repair, almost 70 to 80%, because even today, most of the surgeons are resorting to put a transannular patch. That means they widen because annulus is small or moderate, which we calculate according to the Z-scores. In order to make it roomy, the valvotomy along with that, they put a patch that causes post-operatively almost in significant number of patients, it causes significant PR. Echo and MRI are very helpful in planning the pulmonary valve replacement, either surgically or non-surgically. Optimal timing of the PVR for asymptomatic patients. Any ventricular dysfunction, ventricular dilatation, exercise intolerance. Nowadays, we don't wait the ventricular dysfunction to set in. We do it much early because the surgical results are excellent when you do before the dysfunction sets in. For that, we have a very separate set of Z-scores, rules, what we see in the RV diastolic volumes. We don't go by the symptoms. We don't go by anything else. Of course, echo will give us what which patient should have the cardiac
Recording
MRI.
stopped. Recording in progress.
So the PVR improves the RV volumes. Of course, the arrhythmia persists. Please remember that. ICDs and VT ablation can be offered in selected patients. So now this is a decreased pulmonary flow. Coming to the increased pulmonary flow. In presence in failure with in the child, you have a child example. I'll tell you that the child is a truncus arteriosus. Once again, it's a very standard to make a case for that. They behave like a VSD. VSD we do operate anywhere between 3 to 6 months. But when you have a truncus, they also present with failure. We need to operate much early. So they start having within 1 month, 4 weeks. They fall in PVR happens. Then they start having the failure to thrive, repeated infection. Cyanosis is not obvious. I told you earlier to increase pulmonary flow because this is a case with a significant amount of flow is going to the lungs. Presents to the deepening of the cyanosis with the onset of within 3 months, they become terribly cyanosed. We cannot operate at that time. So all these conditions of increased pulmonary flow in general, they present with a heart failure, cardiomegaly. Second heart sound is variable. If there's a truncus, only single second sound. If there is a TGA-VSD with the pH, once again, second sound, you can have virtually like a single second sound. Third heart sound is gallop because increased pulmonary flow. Insignificant systolic murmur. So this is another thing, cyanosis. You don't have any significant murmur. So start looking at the X-ray, you do the pulmonary plethora. So start thinking about of the increased pulmonary flow situation. That means a cyanotic heart disease with the increased pulmonary flow. Cardiomegaly and plethoric lung fields, ECG biventricular forces. The cyanosis depends on abnormal GA relation. That means great arterial relationship, abnormal streaming, increased PVR. Just to give an example, I told you TGA VSD, though they are operable up to 2 months of age, though it is an increased pulmonary flow, though it is a increased pulmonary flow in initial stages, also they'll have a decreased pulmonary vascular resistance. PVR start rising later. In a TGA VSD, the cyanosis is much faster. They will be cyanotic in the first 1 or 2 weeks of life compared to the truncus arteriosus, because here abnormal great arterial relation is a parallel mixing. Whereas in a truncus arteriosus is an admixture cyanosis at the arterial level, abnormal streaming, univentricular heart. There is only one ventricle, but still you do find some of the conditions they behave like a VSD. We cannot make a diagnosis of a single ventricle unless you do the echocardiogram. There is something called a streaming. So the pulmonary flow, still the PVR is very low. A lot of streaming goes towards the pulmonary circulation, causing a very, very less cyanosis. Okay, increased PVR. Once I think this is one thing which matters a lot in the cyanosis origin. There is a PVR within 1 or 2 months of any of these cases with this pulmonary flow, the children will start having the terrible cyanosis. So transposition physiology means what? The circulation in parallel. The PA saturation should be more than the aortic saturation. Unfavorable streaming compared to the other admixture cyanosis. Admixture cyanosis can be at 3 levels. One is at the atrial level, DAPVC, ventricular level, the univentricular heart, the great arterial level, the truncus arteriosus. Unfavorable streaming. A severe cyanotic note even at birth, though they are increased pulmonary flow. Most common cyanotic heart disease in a newborn period. Need shunts for the survival, either the ASD level or the VSD level or the PDA level. The best circulatory mixing happens in a transposition physiology or a TGA is at the ASD level. That's why this is how it looks like. The first echo picture shows the LV giving rise to a branching pulmonary artery, which is not very difficult. You don't see the great artery in that kind of a branching way. That means it is very easy to make a diagnosis. What we need to think, okay, child is cyanotic, the artery is not like that. You can never get the standard short axis view of the aorta and pulmonary artery in a TGA. That will start giving you suspicion and you start thinking about some of these conditions. Okay, admixture physiology. Here the aortic saturation is more or less same as the pulmonary saturation. Once again, take for example admixture physiology, TAPVC. Aortic saturation will be like a pulmonary saturation because everything is same. Usually presents with a failure to increase pulmonary flow. Will go for early development of a PVOD compared to other lesions because of these cyanosis. That's the reason that you should know the natural history, you should know the physiology. Of course, anatomy is important to plan the management of the strategies, the management. So admixture lesions are pre-tricuspid TAPVC, tricuspid atresia, mitral atresia, common atrium. What is the tricuspid atresia? Because the mixing is happening at the atrial level. Mitral atresia, once again, it is happening at the atrial level, common atrium. Okay, the two ventricles are there, atrium or only one common atrium. There is a lot of mixing is happening at that level. Post tricuspid univentricular heart, DORV, because both have the same pressure to mix each other. The great arterial level, truncus arteriosus. But coming to the TAPVC, there are 4 types, you know that. Clinically, it is not easy to differentiate which type of TAPVC, supracardiac or cardiac. Of course, infracardiac, you can make a diagnosis on the basis of the X-ray. It shows almost all the cases of infradiaphragmatic PVC, there are obstructive. So you can have a pulmonary venous obstruction, pulmonary edema picture. Otherwise, it is extremely difficult to clinically make out a diagnosis, but the echo will come to your help. Echo is the cornerstone for the diagnosis of all these congenital heart disease, more so with the TAPVC. 4 type, mixed type. So obstructed or unobstructed is once again important. Please remember, the obstruction does not mean it obstructs only at the infradiaphragmatic variety. No. The commonest obstruction in other types of TAPVC is at the internal septum level. ASD is very small, just a small PFO is there. That itself give rise to the increased airway pressure. It increases the pulmonary venous obstruction, giving rise to a severe pulmonary arterial hypertension or venous obstruction. So obstruction of any of the anomalous venous channels, intrinsic narrowing can happen, extrinsic venous compression. Infradiaphragmatic AVC is usually obstructed, but it has a femoral stemming. So what is the importance of knowing obstructed and unobstructed? That is because in a case of a obstructed TAPVC, either any level or the infradiaphragmatic, the child has to undergo surgery within a couple of hours or a couple of days. In a TAPVC, other variety, any TAPVC after 6 weeks, unobstructed varieties also should get surgery done, because this is a near curative surgery. Surgical results are excellent. One infection can knock out the child. That is why making the diagnosis of a TAPVC early in the game is extremely important. In brief, hemodynamic of unobstructed TAPVC is like any AST. Hemodynamics of obstructed TAPVC is like a mitral stenosis. Please remember this. So ECG is a tall peak, so I don't want to go into the detail. Is RAD, RVH, like any other pulmonary artery pressure, or the right pre-tricuspid shunt is the feature in any of these things. This is an older child, comes with a TAPVC diagnosis. This is a non-obstructive generally, supracardiac TAPVC left arm brain. The this diagnostic sign, figure of 8, is not present in the first few months of life. Don't start looking at the X-ray in a newborn child or infant. It doesn't happen. It has to happen over a period of few months, a few years, to make those venous channels dilate. Obstructed TAPVC, you see that the pulmonary edema is very apparent in the lung fields. Diffuse reticular pattern, cardiac size is normal here, curly B lines may be present. So a few examples of supracardiac TAPVC. So how to recognize this supracardiac TAPVC? The moment you put a probe and the echocardiogram, you find that there is RA and RV dilated. You find the pulmonary artery pressure in the TRZ is there, is 50, 60, 70. Start imaging the pulmonary vein. This is extremely important because this is one of the curative conditions. In 9 out of 10 cases, you can cure the problem if you do the surgery at the right time. Okay, if you can't image the pulmonary vein in a severe PH, start looking at what are the common types of TAPVCs, supracardiac. Just by the side of the left atrium or the pulmonary artery, if anything red flow goes like this, that means it is some pulmonary veins are draining to the vertical vein into the innominate and coming back to the SVC. So coronary sinus. Coronary sinus is grossly dilated and opening, the red flow is opening into towards the RA. You're not able to see the pulmonary, veins properly. Almost you are sure. Along with that, you have to make a diagnosis of a AST or intrathecal communication, which is right to left shunting. This is mandatory. Almost all TAPVs, ASD shunting is right to left. Please remember that. So supracardiac you ruled out. infracardiac, the cardiac PVC, either SPC or RA junction, you can image that. Coronary sinus PVC is very easy. If you're not finding any of those veins there, then start looking at the liver. See, in liver, this is not a picture. If you go to the subcostal view, one is a pulsatile flow, another is in the liver. Liver, you don't see that. You normally see the hepatic veins, the IVC, in a blue flow. If you start looking something going down the liver in the red flow, along with the parallel to the aorta, that means something going down to the liver below the diaphragm. And if you see the turbulence in the hepatic vein somewhere, almost always you are sure you are dealing with the infradiaphragmatic PVC. So this is not very difficult. Hemodynamic ways, ascending vertical vein gets obstructed because of the dilated LPA. So this is few cases. You see the pulmonary artery bifurcation. By the side, you see the red flow is getting something obstructed there. You do the PA pressure is very, very high. Truncus arteriosus is not very difficult. Truncus arteriosus, please remember, almost always associated with a large, small aligned VSD. And you don't see the commonest diagnosis, which you need to know about in this case, is a pulmonary atresia VSD. So here, how to recognize what is the nearest diagnosis? One is a single arterial trunk will be there in both the cases. Both the cases will have a large VSD. But go to the suprasternal view. And in a pulmonary atresia VSD, you find the duct many times, small duct giving rise to the tiny pulmonary arteries. In a truncus, you go to the suprasternal, you find the big LPA and RPA. So it is, you have to use the suprasternal view to differentiate these two conditions. So Eisenmenger, a couple of slides, is an evolution, is a state of evolution of increased pulmonary flow physiology. Increase in the PVR curtails the left-right shunt. Common in adult cardiac practice along with the adult etiology. This is, so Eisenmenger state is a severe cyanosis. As the age advances, there is absent flow murmur, absence of murmur due to the ASD, VSD, PDA. New murmur like a TR will develop in a ASD, or it can develop in any of the shunt lesions. PR in, especially if there is a severe pulmonary arterial hypertension, in any of these three shunt lesions, you can have a development of a PR murmur, loud P2. So differential splitting. In a ASD, split remains wide and fixed. In a VSD, single second sound. In a PDA, it is narrow split, though you can appreciate this split, it is a very narrow split. So, except in a ASD, this establishes in the first 1 or 2 years. Don't think that a VSD takes 18-20 years to develop Eisenmenger. No. Within 1 or 2 years, the whole process, the pathogenesis will start. Okay, that is the reason that we need to operate them as early as possible before 6 months of age. In ASD, you can wait. VSD, they don't develop Eisenmenger till the 3rd decade or 4th decade. Survival is better with IPH, better than IPH. More often than not, intervening Eisenmenger causes more than. So we should never operate these either Eisenmenger situations like ASD, VSD, PDA, because we do more harm. We are converting them to the IPH because Eisenmenger is always better than having a IPH. So these are all various causes. You know that any kind of shunt lesions can develop pre-tricuspid or a post-tricuspid or any kind of a complex heart disease with increased pulmonary flow. By nature, they develop Eisenmenger. Okay, so Eisenmenger, so the first one is Eisenmenger syndrome. Second one is a PH, the moderate to large defects. PVR is mildly to moderate to increase. Systemic to pulmonary shunt is still present, but no cyanosis are present. But still, there's a possibility of operating here. PAH with small defects. You have a 4 millimeter, 3 millimeter in a 10-year-old child with a VSD, but the severe pulmonary arterial hypertension. So that means that pulmonary arterial hypertension is not because of this VSD or not because of the ASD shunt lesions. Okay, so then you cannot operate them. You are going to do harm. So we have to make sure that that shunt lesions are large enough to cause pulmonary arterial hypertension or Eisenmenger. PAH following a corrective cardiac surgery. So you do the surgery, but probably you've done the surgery of a VSD closure at 1 year of age, still the already irreversible pathogenesis is setting. But somewhere along the way, in almost 5 years or 10 years down the lane, they develop the PAH. Though you've operated, you've converted a large VSD with a PH into a primary pulmonary hypertension kind of a clinical situation. So how to present that, whether there is possibly that means what lesions were there, failure to thrive with infancy, better with age. First insidious presentation in adult is effort intolerance and cyanosis. Cyanosis at birth in some complex disease that we know that they would have told you. So better not to have this kind of a clinical situation, not to operate the children early in the game and leaving them Eisenmenger, which is worst thing to happen to a child where we get a sorry figure in front of them, the parents. So central cyanosis is a rule in a VSD and a AST. In a different cyanosis is in PDA. Clubbing, JVP is in a large VSD unless there is a TR, unless there is a ventricular dysfunction, which is not a feature in a VSD and the PDA. Dominant A wave is there in the AST. Precardial palpation, right ventricular heave in AST, not in a VSD. Some amount of RVH can happen in a PDA. Palpable P2, loud P2, high-pitched EDM or murmur, PR murmur. You don't get any systolic murmur here. RVS4, pulmonization click, short, all shunt murmurs have disappeared. So I don't want to go into the detail of these things. I think I can forward the slides to sir, and then I think he can share with you. So recognition of the various type of the ECG is once again a recognition of the shunt lesion in the base of the ECG is extremely important. In ASD, there is a rated enlargement RVH. Features of LV enlargement plus RV is a PDA with VSD. Cat-Bad cell phenomenon, EQ-phasic QRS still suggests that their operability. In the ASD, you see a lot of rhythm abnormalities, left axis deviation is a feature in ostium primum ASD. So the RV voltages, QRS duration, QTC interval are poor prognostic indicators. So right axis deviation RVH, VSD, PDA, ASD, RAD with right axis with LVH, single ventricle, same thing which I described to you in the golden slides. Imaging right-sided diode in all of these things. The 16% of the VSDs can have the right-sided aortic arch. The X-ray will give us calcification of the duct, dilatation of the MPA, pulmonary alechemia. These are all the X-ray. How to look into that. These are all see the X-ray imaging of these, some of these conditions of the Eisenmenger situations. Pretty bad situation. See how the pulmonary arteries are dilated. So RPA and LPA. The CT imaging we do. This is the survival curve for the Eisenmenger syndrome. They do well. It is not the same. Dr. Krishna Kumar gave the last lecture at that time. He did tell you people that they are not as bad as what used to be because of the vasodilators and our education to the patients and so on. They're not bad. So life expectancy is not like what it used to be. Okay. Difficult clinically to distinguish pulmonary atresia with severe TRF from Eisenmenger's. Common features, how to differentiate with this Eisenmenger is no cardiomegaly, common features, quiet pericardium, single second sound, but it differs. There is A2, here is P2, HN click in both, no significant murmur in tetralogy of pulmonary atresia because of the polycythemia. ER in tetralogy, PA and pulmonary regurgitation in Eisenmenger. So these are all some of the common features. You can have the murmurs, you can have the HN click, you can have single second sound, but very, very subtle signs will differentiate between both. So history, Eisenmenger, cyanosis, heart size, you see that how they can sometimes mimic all these things. Okay. A note on Epstein's anomaly, I told you it's a spectrum. It is not a single entity. Can have a mild Epstein's or a severe form of Epstein's, can present with palpitation, excess intolerance, depends on the severity of the Epstein's anomaly. RV dysfunction is due to both tricular displacement and reduction in size of functional RV and RV myopathy. So it is not only because of the Epstein per se, it is because of the reduced reduction of the size of functional RV and some kind of a myopathy sets in all these conditions. A left-sided disease in about 40%. So AFD and PFO is a rule in 80%, WPWS syndrome 5 to 25%. On examination, the M1, T1 split, A2 to split due to RBBB, S3, S4 often present as well. Murmur, it's an organic murmur, infrequently heard, very, very short. You can easily miss that. This is a very classical ECG where you see the Himalayan P waves, incomplete RBBB pattern, QRS fragmentation, PR prolongation, right-sided leads, low voltage, so on and so forth. This is very classical, downward display from the tricuspid valve. To conclude, anatomy dictates the survival and management options in CCHD, cyanotic heart disease with a decreased pulmonary flow. Anatomy is extremely important. Physiology is not so important here. Anatomy and physiology both dictate the survival in a cyanotic heart disease with the increased pulmonary flow. Knowing these two things are extremely important. And natural history, of course, is extremely important. Clinical examination should be supplemented by a lot of other imaging. Recognition of these lesions are extremely important, since some can have a definitive treatment, some can have a near curative treatment. Thank you.
Thank you, Dr. Jayaranganath. A great talk. Within the short time, I think you have given a lot of tips and tricks to the students how to recognize these cyanotic congenital heart diseases and when to intervene within short time, especially in the TGAs and of course TAPVC with obstruction, all these things, and at least sometime in other conditions also. And you have already given a holistic approach has to be done, including the history, physical examination, especially the ECG, echocardiograms. All these things are going to help in the management aspects also, and to make them survive more into the community. And any questions? I think chat box there are.
No question there.
I think your talk has, there are no questions at all. Probably it's a very clear talk. Lot of messages you have given to the students. And can I ask other professors, Dr. Nagaraj and others, any other comments?
Okay, sir.
Any limitations of hyperoxia test?
No, that actually we don't do that often, sir. No, I think we just do the bedside saturation. Actually, we never do the invasive like ABG monitoring and all. It's not relevant with the advent of this echocardiogram, bedside, so many things. It's not really relevant. It's not really.
Mm-hmm.
Yeah, but what we do, even in the OPD, we do a couple of things like when a borderline situation comes that it's not hyperoxia test. We do give oxygen for some children to see that if the saturation goes from 90 to 98%, that means we say it's operable, so that we can advise the child for a catheterization. Otherwise, if it does not improve, that's only do give that. Otherwise, hyperoxia test is just for the completion sake. I mentioned that.
Yeah.
It's not any relevant now.
Thank you. Any other questions from others? Students? Sir, I request you to do the concluding remarks.
It was a masterly presentation, and I think all of us who have been here, and particularly students, they have not only learned things, they also learned what are the questions to be expected and
Yes.
so if you learn the basics like what he has told, it will be very easy to answer the examination. So I thank Dr. Jay for this excellent presentation, and also thank you for accepting, at a short notice, I was in the problem. He came to my rescue. And we look forward to many more such.
Yes. I think another time we can come with the management aspects also.
That's
If possible.
That's important. Management is equally important, not for the exam point of view, but all these people should know it.
Yes, yeah, definitely. In that way, at least to give more knowledge to the students as well as the practicing cardiologists.
Yes, sir. Yeah. I hope that this is quite useful for the students. I hope this.
Definitely. It's a great talk.
Time you have to rush through, but what to do, sir? What to do?
Yes.
Lot of tips you are given.
Yes.
So I can share this thing, sir, to somebody.
In the Mac group, will you be able to send these slides?
Yeah, I'll send it tomorrow, day after tomorrow, sir, so that you can
definitely.
explain it to students. Yeah, because a lot of things I did not explain, especially the theories and all. I didn't want to explain too much.
Yeah, if you don't mind, I think you can share the slides.
Yes, sir.
It will be very much helpful to them.
Yeah.
Thank you very much again.
Thank you, Dr. Patil.
Thank you, sir.
My colleagues who logged in, thank you very much.
Thank you, sir.
Thank you, sir.
Our team from Medical Hospital.
Thank you, sir.
Thank you, officer.
Thank you, sir.
Thank you all, and good night. Good night.
It's a really good talk.
Recording stop.